Welcome everybody to this CA-CVI tutorial on the principles of cardiac CT examinations and radiation safety. Today we have two real experts to talk you through this topic. We have Ronny Büchel from Zurich in Switzerland and Francesca Pugliese from London, UK. And now I have Stefan to explain to you the learning objectives.
The learning objectives of this tutorial are fivefold. To understand the basic principle of image creation with CT, to understand the requirements for cardiac CT, patient and device-wise, to select optimal imaging protocols based on patient characteristics and clinical questions, to understand the principle and apply approaches leading to X-ray dose reduction in cardiac CT, and finally to be aware of the most important safety aspects.
This is the first tutorial in a series of tutorials on cardiac CT. I suggest we start off very basic. Can you explain to us maybe how CT images are actually acquired?
It's very important to discuss some of the important components of a CT scanner. The gantry, of course, the X-ray tube that generates the X-rays, and the detector. The gantry has three important features that we should mention. The slip ring technology. This means that the transfer of data and power between the housing of the scanner and the gantry is not done by any cables, it's done by a metal brush, so that there is continuous contact between the housing and the gantry. The switch mode power supply again means that the power supply is powerful enough, but at the same time small enough that it can be mounted on the rotating gantry. And these two features are key in order for the scanner to be able to rotate fast, to have a very small gantry rotation time, which is a key feature for high temporal resolution. Now, clearly, a key element of the CT scanner is the X-ray tube to generate the X-rays. What happens here, we're basically heating a filament of a metal, typically of tungsten, with a current and generating electrons that get accelerating from the negatively charged cathode to the positively charged anode, and they gain energy which is obtained by applying a difference in potential between the cathode and the anode. And when they hit this part of the scanner over here, the focal spot, the energy of the electron is released into X-rays or X-ray photons, and the beam is therefore generated. Now, the energy of the X-ray beam is not homogeneous, so the beam is, we say, not monoenergetic. There is a spectrum of distribution of the energy of the beam that varies. So a minority of the X-ray photons will have very small energies, and the majority will have an energy which is roughly half of the maximum of applied potential. As you see, there is a continuum distribution of the X-rays with a couple of peaks corresponding to the characteristics X-rays. And finally, the detector. The detector is important because it collects the energy deposited, absorbed from the X-ray photons, it converts it into light, and then the light is converted into electric signals and hence in images.
Okay. So now that we know how to obtain CT images in principle, if we come back to cardiac CT, that's a bit different because the heart, as we know, is a different organ than other organs like the brain, for example, which just lies still. The heart is moving. So can you tell us a little bit what the challenges are and what is special about cardiac imaging when we try to use CT for that?
Certainly. I've got here some artifacts that are way too common in cardiac CT. Some artifact from motion, heart motion or respiratory motion, that can be related, as said, also to ECG interpretation errors, and some artifacts related to insufficient spatial resolution of CT, beam hardening and partial voluming. We see an example here of a CT in a patient who has a calcified plaque in one of the vessels, and because the calcified plaque is so bright, is so dense in CT, it makes really difficult the interpretation, or the visualization, I should say, of the vessel lumen. And in the same patients who underwent invasive angiography shows that actually the sag segment in the same artery is actually absolutely fine. So this can be a problem in the interpretation of the images. So an example of this for what concerns spatial resolution is shown here. you see again a CT image of a patient with a diffusely calcified vessel. What we are trying to do is to image that vessel with the digital imaging techniques, and what you see represented here are the different voxels. So when a voxel is partially filled with a tissue which is really, really dense like calcium, the final attenuation that is assigned to that voxel will be the average of all the tissue contained in the voxel. So that means that the attenuation values will be increased and the structures will be displayed bigger than it actually is on the CT image. So this is a limitation associated with insufficient spatial resolution. Spatial resolution being defined the smallest distance at which two different points can be distinguished as individual objects. Also paramount in cardiac CT is, of course, temporal resolution.
Because the heart is beating.
Because the heart is beating
different
all
from
the
the
time.
brain, as we said.
So temporal resolution is defined as, in a camera, like the amount of time that is required to acquire all the data that are needed for the reconstruction of one image. Typically, in a single source CT scanner, that equals to half of the gantry rotation time, so the image window can be represented as here. And in a dual source CT scanner, which has a different geometry with two X-ray tubes and two detectors operational at the same time, that can be reduced to a quarter of the gantry rotation time, thus achieving a geometric improvement in temporal resolution. Again, I want to show you an example of the effect of temporal resolution on image quality. Here we have the same patient who was imaged with the dual source CT scanner. We constructed the picture with a temporal resolution of 165 milliseconds, and then the same picture with the temporal resolution that is halved, of 82 milliseconds, and you can see by yourself the massive impact on image quality in this cross-section of the right coronary artery.
So by using different scanner techniques, different scanner technology, you can improve temporal resolution to overcome one of the challenges that you just mentioned. You also mentioned artifacts. You also mentioned spatial resolution. So what are the needs? What do we need to do in order to overcome those challenges that come with cardiac imaging, cardiac CT?
Certainly, the first thing to do is considering patient preparation, appropriate patient preparation with arterial control, because temporal resolution still remain a limitation of cardiac CT, even with contemporary technology. So it's absolutely common practice to administer beta blockers, and metoprolol is the commonest used, usually intravenously or orally administered 1 hour prior to the scan. It's also extremely common to administer 2 sublingual sprays of GTN. And also important, let's remind us, to instruct patient very accurately and rehearse the instruction about the scan, making sure that the patient is aware of what's going to come, the feeling, for instance, of the contrast injection, so that he or she can really cooperate as best as possible with the instruction, the breath hold, for instance, and give us excellent image quality.
May I ask, Francesca, what do you do in your institution? What kind of regimen? Do you give beta blockers orally, or do you give them intravenously?
We usually administer beta blocker intravenously just before the patient goes onto the scanner. That's our practice.
To reach that target heart rate then.
Yeah.
And what is the target heart rate that you
Well, the target heart is usually lower than 65 or lower if possible, but certainly with modern equipment it is no longer a contraindication to scan patient with
more or less
heart
the
rates.
range there. Yeah.
Certainly. So we mentioned another very important thing to remember in cardiac CT is the choice of the appropriate protocol. ECG synchronization. Clearly, images in cardiac CT need to be synchronized with the vectorcardiogram. Otherwise, we would have images that are blurred because of the cardiac motions. There are 3 main protocols in cardiac CT. The definition and the description, I should say, is valid more or less across vendors. We have a retrospectively ECG-gated helical scan mode, applied almost invariably these days with current X-ray tube current modulation, which has been the first protocol introduced for cardiac CT. And in this protocol, as you see here, the X-ray tube is active all the time for the entire cardiac cycle while the table is moving. So we have a chance to reconstruct arbitrary phases in the RR interval. So this is ideal for those situations in which we need a dynamic study, for instance, a left ventricular functional analysis, or when the patient has a very irregular heart rate, because with this protocol we are able to actually manually edit the pattern of reconstruction of the pictures to compensate for very irregular heart rate. The working horse of contemporary cardiac CT is probably the prospectively ECG triggered or sequential scan mode, where the X-ray tube is active only for a predefined imaging window when the table is stationary, is not moving. So we will be able to reconstruct pictures only within the imaging window. However, the imaging window can be broad and can include both systole and diastole. So we can, in principle, obtain left ventricular diastolic and systolic volume 2. Now, this is the most important protocol these days, I would say, because certainly it's valid for scanning patients with slow heart rate, but also patients with fast heart rate. All that it requires is a relatively regular heart rate, but not absolutely regular heart rate, because the scanner can monitor the previous 10 beats and on the basis of that adapt the way it's triggering image acquisition. And finally, we've got a prospectively ECG-triggered high-pitch helical protocol, or in a scanner with a very big detector, the volume scan, where again X-rays will be produced only for a predefined imaging window during the RR interval, and reconstruction will only be possible then. But these typically, if it's a spiral scan, will have a very high pitch, and this means that the patient needs to have a slow and stable heart rate most of the times. It's also a protocol that can be used in pediatrics even without ECG synchronization.
Maybe just to explain this a little bit more, if I may. So this last protocol that you just explained can be done either with a high pitch or with a single shot or step and shoot technique, but then you would have to have a large C coverage, while here we do have multiple steps. Multiple acquisitions.
So in prospectively ECG triggered, you would acquire your volume in different stacks, whereas in this protocol, you would acquire the entire volume in one single acquisition. So inevitably, that imaging window will be broader. Typically needs to be positioned in the diastolic phase, and it can be acquired either by a single rotation without table movement if the scanner has a large detector, or, for instance, in a dual source CT scanner, will be a very high-pitch helical scan. But in both cases, the acquisition will be limited to one heartbeat.
Yeah, so that's a difference there. Yeah.
Now, I was mentioning that the prospectively ECG-triggered protocol is the working horse of contemporary cardiac CT and is certainly valuable to scan patients with a fast heart rate. And the reason resides in this. So you see here variation in heart rate. So at increasing heart rates, there are changes in the duration of the systolic phase and the diastolic phase. And whereas in patients with slow heart rate, the diastolic time is significantly longer than the systolic time, this changes as the patient heart rate increases. And in patients with extremely fast heart rate, 120, 140, the duration of the systole and of the diastole is actually very similar. And it becomes at that point easier to accurately predict the beginning of the systole and then the telesystole where you acquire your images, as opposed to predicting the diastole, which is the basis to explain why in patients with a fast heart rate, typically above 80 or 90 beats per minute, is systolic imaging that is invariably required to evaluate coronary arteries, as opposed to diastolic imaging. I have an example of such a patient with a heart rate of 108 during the scan, who was successfully examined with the prospectively ECG-triggered protocol, sequential scanning or step-and-shoot mode, where the acquisition window were positioned in diastole. And although image quality is probably moderate, it is still absolutely sufficient to rule out any significant coronary artery obstruction. So a diagnostic examination for sure.
Just from your experience, when do you shift towards a systolic triggering versus a diastolic triggering? At what heart rate? What is your cutoff? Or do you have a cutoff, or does it depend on the
roughly
patient?
In patients with a heart rate above 80 beats per minute, we would apply a systolic triggering, exclusively systolic triggering. Okay. In patients under 65, you can safely use diastolic only. And in the range in between, it's a bit less easy to predict which is best. So we still quite often apply a broader imaging window that includes systole and diastole for those patients.
So CT or imaging is one, but we also need a contrast agent to see what the coronary arteries look like. So let's talk a little bit about contrast protocols, maybe.
Certainly, with the distal coronary arteries being small, so with the flow in coronary arteries potentially being reduced in the presence of obstructions, or even more so in the presence of calcification or other hyperdense objects such as stents, we need a nice and strong enhancement inside the blood vessels, and this can be achieved by having a bolus geometry that is tall and sharp, so that we can achieve rapidly a high enhancement in the coronary artery. As a target of reference, we should achieve an intracoronary enhancement of about 250 Hounsfield unit. So if we were to image a patient with a kilovoltage of 120, I would probably recommend a iodine delivery rate of 2 grams of iodine per second, but clearly because today we can scan patients more and more often with lower kilovoltage, probably this can be adjusted, and lower concentrations and lower iodine delivery rate may be sufficient in those patients. But it's certainly important to achieve a tall and sharp bolus geometry, especially for coronary artery imaging. Now, radiation dose in cardiac is another problem, of course, because image quality is so important, so sometimes we tend to be a bit conservative, and that may induce the examination be a bit important in terms of the radiation. But patient selection is important. Patient preparation, as mentioned, is key to do this, and the choice of the protocol, of course, in terms of type, in terms of the parameters, and when it comes to kilovoltage and MAS, this day technology comes in help, because the majority of the scanner, invariably I should say, the scanner will select the best combination of kilovoltage and MAS, so tube potential and tube current, to image determinate patients based on the patient body habitus. The scan range, let's remember that dose is linearly proportional to the scan range, so we should limit the scan range to what is strictly necessary. And of course all this comes with training and experience.
How do you confine your scan range? Because that certainly is an important aspect. If you set your KV and MA very low, but if you then scan too much of the patient, it's not very helpful. How do you approach that?
Well, when a calcium score scan is available, that can be an extremely useful data set to tailor your acquisition, which is, in our practice, happens the majority of the time. If that is available, a quite helpful tool is usually starting the acquisition a few millimeters or maybe 1 centimeters above the highest point of the LAD. It's quite important to check the course of the LAD. Sometimes the LAD courses proximally, so we have to make sure to improve.
You have to be careful
that.
there, not
Absolutely.
to cut off the LAD.
And then
Absolutely.
use a minimum number of stacks, of course, to cover the entire heart. Sometimes there's no need of using 4 stacks in a prospectively triggered protocol when we could be using 3, so that would be the key.
Exactly. Aside from adjusting the KV, the MA, and the scan range, of course, it's absolutely key to choose the correct or the most adequate protocol here. Maybe you can say a few words on this.
Certainly. I mean, your point is clear. Kilovoltage and MA are most of the time suggested by the scanner, so it's something that we are given. But a very important point for reducing radiation dose comes with heart rate and patients with fast heart rate. There is a myth in cardiac CT, at least I've heard it from several people, that when a patient has a fast heart rate, the protocol that is employed is retrospectively ECG gated. And this is not really necessary unless there are specific indications, like they require left ventricular functional analysis, or there are severe heart rate irregularities. That's not needed because the temporal resolution of cardiac CT depends exclusively on the gantry rotation time. Really, it is that simple. So the different protocols will handle the data in different ways, but they will all acquire with exactly the same temporal resolution. So there is no really an advantage in using a retrospectively ECG gated protocol. They don't have a better temporal resolution. So what is needed for patients with fast and relatively regular heart rates is basically systolic imaging. And in some settings, applying an absolute delay in milliseconds from the previous R wave as opposed to using percentages may be more consistent. So that would be my main advice in terms of radiation dose reduction in patients with fast rate.
So rather than telling the scanner to scan at 45 or 70% of the RR duration, you tell them to scan at 200 milliseconds, for example. Okay,
milliseconds.
so that's the difference there. Okay. What about the different KV settings? How does that impact images and attenuation. I think this is an important
Certainly.
topic as well.
An important point that has become really relevant in the last few years, because recent scanners have enabled us more and more to scan patients at lower kilovoltage, usually because the generator is improved. Therefore, there are better capabilities of the tube current that allows us to use a lower kilovoltage. Then we take advantage of the attenuation changes of iodine at different energy level, which is beneficial for us, beneficial for the patient, because you can see that actually the attenuation increases with decreasing energies of the photons. So it's really beneficial, ideally, to be scanning patients after contrast injection at the lowest energy level. And if this is the mean energy of the beam, we are here around 70 or 80 kilovolt for tube potential, which is what we would like to be able to use all the time. So certainly, adapting the protocol from larger to smaller patient, which we can do these days, is important and is beneficial and has implication also for the contrast injection protocol.
So this would be a win-win situation, so to say, because you would lower your KV, lower radiation dose exposure, while at the same time needing less contrast agent.
Making the examination a bit safer.
Absolutely. Talking about safety, do you have other safety aspects that need to be addressed?
Well, we are administering beta blockers, usually in cardiac CT, to the majority of the patients. So we have to bear in mind some contraindications to the administration of beta blockers: severe hypotension, severe aortic stenosis, and severe asthma or chronic obstructive pulmonary disease, as well as second and third degree heart block. In my experience, we of course check for all these contraindications, but in my experience, they do not reduce dramatically the number of patients who can receive beta blocker. For what concerns GTN spray, the main contraindication there is also probably represented as severe hypertension. And finally, contrast agent. Contrast agent is, of course, something we administer, and in patients who have severe chronic kidney disease or severely impaired estimated GFR, we probably should be extremely careful to perform an examination with contrast agent, and certainly consider whether there are valid alternatives to avoid the risk potentially of nephrotoxicity. Let's not forget, CT is a test that uses radiation, so another potential risk is that associated with effective dose. Effective dose is a measure of the biological effect of radiation on the patient, and certainly this is something that, with all imaging that uses radiation, is of concern. There is, however, very large variability in the doses associated with cardiac CT, depending on technology and also center experience. But importantly, there has been a very large change over time in the last few years, also secondary to improvement in technology and increase in experience. You see, from a median values reported from scans acquired in 2007 of 12 millisieverts to values that are 1 or 2 millisieverts or even sub-millisievert more recently. So certainly a technique that has become safer in the last few years.
Even with not latest generation, but state-of-the-art scanners. You wouldn't need a high-end, latest generation, very expensive scanner to achieve radiation dose exposures in this range, right?
Certainly not. No, a modern 64-slide CT scanner, if used appropriately with the right of the choice of the right protocols and optimization of the dose saving techniques, will certainly allows us to achieve that in an average patient.
For someone who is not a radiologist now, the millisieverts, 1 or 2 millisieverts, it's different. It's difficult to get a to put that into perspective. Is that a lot?
Well, excellent point. We should really see things in the right perspective. We all are exposed to a number of environmental sources of radiation, really. So the public is exposed to radiation from the soil, from the water, from the air. There is a range of sources of radiation, really. To put it a bit more in perspective, for instance, the cosmic radiation associated to a flight, for instance, London to New York, is equal to 2 posterior-anterior projection of a chest X-ray. Then, of course, there will be a lot of medical sources of exposures. This is few runs from an invasive coronary angiogram. A diagnostic invasive coronary angiogram may be associated with exposure that go between, it varies a lot, between 3, 4, 7 millisieverts, depending on the number of runs and the number of, on the type of problem that is investigated. But we're all exposed to natural sources of radiation. For instance, radon gas originating from the decay of uranium is, will continue to exist. Uranium has a half-life of 4.5 billion years, so we will all be exposed to it. And this equals to an exposure from natural sources of approximately 2 to 2.2 millisieverts. These are values for the UK every single year.
You're lucky in the UK, because
Yeah.
in Switzerland it's twice as high, actually.
Yeah, certain areas in other countries like the US have higher radiation exposure. So to see this in perspective, certainly the scan should be appropriate and should be justified. And this applies to all medical procedures, really. We also have to consider the risk of not carrying out a procedure.
Absolutely.
The risk of having an imperfect diagnosis or even a wrong diagnosis, so the delay in diagnosis and treatment that they may cause, or potentially downstream testing. So it's always about balance between benefit and risk.
It absolutely is. I completely agree, and I would like to thank you very much for giving us your insights on these important topics with regard to patient preparation, also the technical aspects to overcome the challenges of cardiac imaging and at the same time reducing risks to the patient. Thank you very much.
The take-home messages from this tutorial are: CT employs X-rays from a rotating source to generate image data. The heart is a moving structure. It moves with heartbeat, with respiration, and poses particular challenges to CT imaging, which can result in artifacts if they are not resolved. Patient preparation and high-end equipment plays a very important role for the quality of the studies. Large reductions in radiation dose can be achieved by optimizing image acquisition protocols, like, for example, with prospective ECG triggering or reductions of MA and KV. And finally, remember your contraindications to contrast agents, beta blockers, or nitrates. Thank you very much for your attention.